So you've been through the tests, the waiting, and you've had the prostate biopsy. But what happens after the results are in? That's a question just filled with uncertainty. Today, we're going to unpack the latest AUA guidelines that create a much clearer roadmap for that really crucial next step. Think about it. It's the one answer everyone is hoping for. The biopsy is negative. Whew, what a wave of relief. But does that really mean the story is over? Are you completely 100% in the clear? Well, according to these new guidelines, the answer is a little more complex than you might think. Let's dive into why. Okay, so the lab results are back. And the very first step the AUA outlines isn't just a quick phone call saying, hey, you're good. No, it's a dedicated follow-up conversation. And you could argue it's one of the most important moments in this entire process. Let's look at the first key recommendation here. Guideline number 19. It states, and I'll read this verbatim, clinicians should communicate with patients following biopsy to review biopsy results, reassess risk of undetected or future development of GG2+ disease, and mutually decide whether to discontinue screening, continue screening, or perform adjunctive testing for early reassessment of risk. Now, the AUA labels this a clinical principle, and that's not just a suggestion. What it means is that this conversation is considered a fundamental, non-negotiable part of good medical care. It is the very bedrock for everything that comes next. So that guideline really breaks down into 3 clear actions. This isn't a doctor just delivering news from on high. It's a structured conversation. First, you review the detailed results. Second, you talk about the ongoing risk, looking at the bigger picture for any clinically significant cancer, which the guideline calls GG2+ disease. And third, and this is the most important part, you mutually decide what to do next. It's a partnership. All right, let's really zoom in on that negative result. It's the most common outcome, sure, but it's also where the most important details and nuances are hiding. And this brings us to a super critical point in Guideline 20. It states, very, very clearly, clinicians should not discontinue prostate cancer screening based solely on a negative prostate biopsy. Just let that sink in for a second. A single negative result is not a free pass to stop being vigilant. And get this, the AUA classifies this as a strong recommendation. That is their highest level of certainty. This isn't based on somebody's opinion. It means the evidence is absolutely overwhelming that for most people, the benefit of continued monitoring far outweighs any potential downsides. So building on that, Guideline 21 tells us how to monitor. It says, after a negative biopsy, clinicians should not solely use a PSA threshold to decide whether to repeat the biopsy. The big takeaway here, that single PSA score is no longer the lonely trigger on the dashboard. And notice the emphasis here, another strong recommendation. The experts are sending a very clear signal that the old approach, just watching that one PSA number creep up, is officially outdated. This really represents a fundamental shift in thinking. The old road was kind of straight and narrow. Just watch the PSA. The new approach is more like a central hub, a holistic risk assessment. Your PSA score is still a piece of the puzzle for sure, but now it's being considered right alongside many other factors like family history, prostate size, and even the tiny details from your previous biopsy. Okay, so if we're not stopping screening and we're not just watching the PSA anymore, then what do we do? What does this modern, holistic approach actually look like when the rubber meets the road? Well, that leads us right to the path forward. The next few guidelines get really specific, and they lay out the when and the how of this new screening strategy. Guideline 22 tackles that question of when. It reads, if the clinician and patient decide to continue screening after a negative biopsy, clinicians should reevaluate the patient within the normal screening interval, 2 to 4 years, or sooner, depending on risk of clinically significant prostate cancer and life expectancy. And once again, this is labeled a clinical principle, which just reinforces that personalized timing isn't just some nice idea. It's a fundamental part of managing a patient's care after a biopsy. So the key takeaway here is that there's no magic number for when to come back for a checkup. It's a personalized timeline. The guideline says 2 to 4 years, but honestly, the most important words are or sooner. For someone with a higher risk profile, follow-up might be closer to that 2-year mark. For someone with a really low risk, it might be pushed out towards 4. The interval is tailored directly to you. And finally, Guideline 23 details how to assess that risk. It recommends, at the time of reevaluation after negative biopsy, clinicians should use a risk assessment tool that incorporates the protective effect of prior negative biopsy.
Now, that phrase protective effect is just fascinating. It means your clean biopsy is now a powerful piece of data in your favor. It actively lowers your calculated risk going forward.
And would you look at that strength? A third strong recommendation. The AUA is sending an emphatic message here. It is time to move to modern, sophisticated risk calculators. These are tools that can weigh all the different factors and give a much, much clearer picture of your actual risk.
So, we've walked through all the nitty-gritty details. Now, let's pull back and just look at the 4 core principles that all these guidelines are really built on. This is the big picture.
You know, when you boil it all down, it comes to these 4 points. First, this whole process has to be a partnership. Shared decision-making is simply non-negotiable. Second, a negative biopsy is not an all clear. It's a data point, not a final destination. Third, we have to move beyond relying just on PSA thresholds. And finally, everything about the path forward, the timing, the tools, it's all risk-based and has to be personalized to you. All of this leaves us with a bigger question, doesn't it? These guidelines represent a major shift towards personalized medicine. As our tools get smarter and our understanding of risk gets deeper and deeper, are we seeing the end of the one-size-fits-all screening era? This really is a clear move towards a future where medicine isn't just tailored to a disease, but to the unique individual patient.